So welcome everybody. I'd like to start by just acknowledging the traditional owners of the land with which we're gathering today, the Bunjalung people of the Arakwal Nation, and pay my respects to their elders, past, present and future. This is sacred healing land that we're on, and so it's an absolute honour and a privilege to be able to deliver health and healing, education and knowledge. How we got here, first of all, housekeeping. The bathhouse is open, so you can use the toilets in there, and there are toilets if you go into the clinic. Please help yourself to snacks and drinks and teas. There's some beautiful herbal teas and some beautiful kombuchas there as well. How we got here today. So 25 years ago, I envisaged a place where practitioners would come together in a patient-centred model. I knew as a naturopath when I graduated that I had some tools, but I would really need to combine those skills with doctors and specialists and psychologists and acupuncturists. And together we've really come to understand health and healing in all its forms, on the emotional level, on the physical level, but also on the spiritual level. And it's so exciting for me to be able to offer this last part of the vision. 10 years ago, almost 10 years ago today, the 25th of May, we purchased this land, Simon and I, and we've been building this integrative model of healthcare ever since. 6 months ago, we completed the build of our beautiful wellness accommodation and our beautiful bathhouse. Having Pete coming here today, Pete and I have been friends for a while and we hang out at the conferences together. You'll know if anybody gets a chance to have a glass of wine with Pete, the conversation's riveting. And so I'm super excited to be able to have him here just to talk to you all today. But the accommodation, a lot of the principles that I've put in place are based on a lot of what Pete will be talking about. So there'll be lots of questions at the end, if you could please keep them to the end. And I think we're going to be a little bit disturbed as well. And that's okay, because we only learn and change once we understand. So Pete is, here, I've got an intro. We had a chat the other day on the phone. Is a professor 3 times over. So he's a professor of neuroimmunology, a professor of mucosal immunology, and a professor of allergies. And so he's very, very busy. He is also a clinician in clinic and works with MCAS patients, as do I. And he knows the complexities of this condition. He also has a deep interest in the environment and how it impacts on the immune system. He's released some topical creams which are seaweed based, and they're showing to be incredibly useful in oxidative stress, but also we're seeing a lot of stem cell activity with them. So super exciting for skin cancers and hair loss, interestingly. What else have we got with you, Pete? Yes, Pete's currently, hi Oscar, welcome. Pete's currently doing investigations into vaccine-induced injury, and there's a research happening with that currently that we'll email out how to get involved in that if you'd like to be a part of that research. And just released a paper on long COVID and low-dose naltrexone and its natural killer effects in helping to recover from this. There's one other thing. A chat. You just drop things. Also being found an incredible treatment for post-COVID diabetes.
No, that's my son. We're doing that with. So he managed to COVID and his diabetes was left hospital. Said, eat whatever rubbish you like. Have this insulin. You're all fine. 30 to 40 units a day. No, he's down to about between 10 and 30 units a week now, and so
incredible.
Try and modify that.
So it's amazing to have somebody with this clear insight and understanding to the immune system, and modern day environmental issues that we're all facing and viruses that we're all facing. So I could go on, but I won't. I would like to warmly welcome Professor Pete Smith.
Thank you very much. Good to hear you hearing me well. Thank you very much. Thank you for getting here on a Sunday morning, taking away time and family. We do need to move it closer. Okay, I'll swallow it. There we go. Is that better? We're hearing? Okay, fabulous. Thank you so much. When I was doing this, Reine said, talk about this, and talk about this, and talk about this. So I've got lots of topics I'm going to dance through. I've got a lot of depth, but I'm going to skip over some. I'll try and give a good overview that's digestible to the range of people and a knowledge base. I can see some practitioners. I can see some patients. So it's a pleasure to look after my patients. As Reine said, I do look after MCAS, ME/CFS, long COVID, but my limitation, my rate limiting step is me. And I can only see about 2 of those patients a day because they take a long time, they're complicated, and I don't want to de-skill in my other areas either, so I need to keep up my anaphylaxis skills, my rhinitis skills, and that integrates into how I look after these patients as well. So part of my job is to get through that, these conditions, help educate other people to look after them, and importantly, patients to look after themselves, because that's a big part of the journey. So, does mast cell activation even exist? I'm not in a room of people that doubt it, but this is actually me having a bit of therapy. These are statements that I've actually had from colleagues saying our hospital doesn't diagnose that condition, we don't stain for it, therefore we don't believe in it. And I diagnose everybody with MCAS. I've had patients tell me that. I've had patients report to child protection because they don't fit the doctor's knowledge constructs. They get diagnosed as functional neurological disease. There's overdiagnosis of anxiety and depression. MCAS is very associated with POTS. Autonomic symptoms cause your heart rate to go up. You might feel tired and depressed. They score on depression and anxiety scales. And yes, they fit the boxes unless you think about that in the construct of POTS. And I've had patients come to me being told by specialists, I didn't learn this in medical school, you're too hard to manage, or you're outside my pay grade, my very well-paid pay grade. Case study, with permission, 16-year-old female with fatigue, hypermobility, urticaria, bloating, cramping, abdominal pain, vomiting, gastroparesis, and bouts of tachycardia and dizziness, and headaches. She had POTS and she was intolerant to temperature, not something too uncommon. We checked her mast cell staining in the duodenum and there were 43 mast cells per high power field. So you need to ask more than, it's CD117 mast cell staining, not just mast cell staining. If we stain for tryptase and the cells are dead, we may not pick up mast cells. CD117, and it's a median of 10 high power fields. Her baseline tryptase was 6.2, and she was been on H1s and H2 antihistamines, but she was having episodes of sharp, sudden onset chest pain and collapse. She was flushed, she was passing out. On ECG, she had ST elevation and raised tropomyosin, 1 to 2 episodes a month. She was scared. She felt she was dying with these episodes. And they tend to be more severe in the days before her period. And that's not unsurprising because mast cells get twitchier with progesterone and estrogen. In fact, the nerves that excite, at least neuropeptides do. And she had cardiac and neurological reviews. Cardiac-wise, Holter monitor, they showed ST elevation and tachycardia that are associated with the collapse. She had a normal echo, normal angiogram, and essentially was told she was normal. There was an idiopathic acute coronary artery syndrome, normal examination, normal MRI, normal EEG. But as a neurologist, they were actually compelled to call it functional neurological disease and send them off to mental health. Totally in their own silo, but in fact what this patient had is Kuhn syndrome, which is cardiovascular disease when mast cells will degranulate and cause coronary spasm. And it was causing acute coronary events. And it was so she was flushing, she was getting hives and passing out. And we basically got her on mast cell stabilising antihistamines. In fact, because of her urticaria, she was able to get omalizumab because she had chronic spontaneous urticaria. And episode 3, confident, happy, and she's living her best life. It's lovely to have patients come in, have the joy and safety and security. And I just actually recently had a UK medical student with me, and she was saying, your patients come in and hug you. And that's very APRA non-kosher. But there's joy, there's happiness. One of the best things I see, I read patients as soon as I see them. I'll actually see as they jump up, as I'm seeing them the second or third time, smile on their face. I know they're getting better. They can see themselves on the path, and they share that joy. I don't, and it's lovely to accept and recognise that. I don't expect hugs, but they want to share their joy, and that's lovely. Now, revisiting those, I'm over it. We've shared, but this is the front cover of Jackie in Practice, August 22. The front cover of Jackie, the most cited allergy journal in the world. So with that, I've just got some zoom-ins. MCAS is on the front cover. So there's some disconnect in hospitals where they say, no, we don't diagnose it. Or specialists who say, don't believe in it. And the leading, most cited journals in the world. And it can take quite a while for knowledge to become practice. Now, willful blindness is basically closing your eyes to the fact that it probably exists. And what's worse than the blindness and saying, I don't know, is actually telling patients that you've got knowledge in the area and it doesn't fit their knowledge, therefore it's you. So patient blaming. So I've dealt with many patients who've actually, as part of their threat complex, is medical trauma. First, do no harm. It's, Hippocrates. It's the foundation of medicine. So how long does it take to recognise change in medicine? Audience, let's get you awake, engaged. How long?
20 years.
Okay, close to Simon. Statistic figure looks like, this is pretty close, 14 years ago, said it took 17 years for scientific discoveries to come into practice. Because research and dissemination implementation. But you think, we've got technology, we've got social media. No, it's slow. And we've also got so much information these days. When I went through medical school last century, there'd been 2 million papers published in the history of science from 1655. At the moment, it's about 70 to 80 million. And we've had 500,000 on COVID. So, people also get told, we learned it all in medical school. And it's in our construct. So introducing new constructs is challenging, but also it's hard for doctors to say, I was wrong. You've actually got to go against that tidal wave as well, or that wall. So first they ignore you, then they laugh at you, then they fight you, then you win. So, after the introduction, what is mast cells, or what are mast cells? There's actually a whole part of mast cell syndromes. Mast cell biology. Mast cells are basically they've developed over hundreds of millions of years across animal species. They're highly metabolic cells, and they have mediators that they ooze out and also release in the presence of threat. And across the evolution, we've got more switches as we've evolved. One of the interesting ones is actually histamine. So we ooze out histamine from our mast cells. Why is that important? Well, if mast cells are there and there's damage, they want cells to be able to migrate in rather than create a clot. But if you're oozing out histamine, you have, for women, you have heavier menstrual losses. So these are the patients where you'll find difficulty in keeping their iron levels up. You'll give them iron, and they might have 2 or 3 iron transfusions again. The haematologist going, no, it's not GI. They'll get endoscope. It's actually heavier menstrual losses, or even in men, heavier GI losses. So heparin is important, and it is a marker of mast cell activation. So as we evolve, we've got more switches,
and potentially more ways for things to get wrong. Now, mast cells will break open if we make autoantibodies against them. There are hormonal factors, infection, complement activation, food chemicals and preservatives, physical factors, heat. You'll flush and have your mast cells break up when you exercise. See a kid crying and come up in little welts. So emotional and neurological. And there are medicines that can cause mast cells to open up and degranulate. Additives as well. Sulfate's a great example. So allergic response, this is my bread and butter. Basically, an immune response, mast cells will see that and try and destroy that threat. So allergies are not a weak immune system. It's too good an immune system, but it's stupid. It's actually seeing a threat that is not really a threat. And same with Mast Cell Activation Syndromes, the body is trying to heal and protect, but injures nerves. Nerves get excited, release mast cells, and we get into this circle within circles. And then it upsets the autonomic nervous system. So mast cells are meant to be good. They help with parasites and wound repair and destroy things and envenomation. But they also can be dysfunctional and cause allergic responses, hives. We find more of them in our patients with MCAS. We're finding more of them in our patients with long COVID and a condition called mast cell activation that we're actually seeing more of. Mast cells are in high distribution where we come into threat. So our hands, face, feet. And this is from a lovely friend of mine, Marcus Morter, who I've done work with in Berlin and still doing work with their group. So mast cells and nerves are in high concentration where our body meets the external environment. So anybody who's had an allergic reaction, they might have started getting itchy hands and itchy feet. But where our body comes in contact with threats, so our eyes, our nose, where things transit through our body and also enter and exit the body. So rectum, vagina, bladder, more hypersensitive than threat. So when things go wrong, those are the epicenters of danger where mast cells and nerves coalesce. And they're guardian sites. Now, MCAS, not to scale, this was taken from a review about 8 years ago. So there are disorders associated with mast cell activation. And I'd say MCAS is one of those. Mast cell activation generally is one. We'll have clonal mast cell disorders called like mastocytosis, where people have too many of them, and idiopathic anaphylaxis fits within that group as well. I'm not going to try to get you to read all of this, but there's actually there's categorization of it as well that was put out a few years ago. But this is criteria for primary MCAS and secondary MCAS are fulfilled, and we'll talk about that later in the talk. But there is a high risk of having severe allergic reactions. But primary conditions could be where we've got more mast cells about anaphylaxis, hay fever, rhinitis, EOE, asthma, allergic conjunctivitis, and chronic spontaneous urticaria. Up to 20% of people in their life will get hives. Now, the epithelial injury, when there's epithelium injured, half the acetylcholine, and you've heard of acetylcholine, neuromediator, half of it's actually from non-neuronal sources. So we think of it as being presynaptic in the parasympathetic and parasympathetic nervous system, postsynaptic and parasympathetic, precursor to noradrenaline in the sympathetic nervous system. But it will tell the body it's alive. It's a whisper of life. But when there's danger, there's more of it. So mast cells will get activated easier, nerves will get activated easier. What do we got? So MCAS, this is just saying, using a criteria, which is from Karolinska, severe recurrent mast symptoms for at least 2 organ systems, laboratory events, and response to mast cell activated targeted therapy, which was injected in practice about 5 or 6 years ago. Trip days, we say, yep, to have mast cell activation, you've got to have trip days elevated. That's what we use for mastocytosis. Only 15% of patients with MCAS will have an elevated trip days. It's good to get because if it elevates more than baseline, plus 20% plus 2, you've got an indication of mast cell activation event. So if your basal trip days is 5, you have an event measured hot. It's got to be measured quickly because it degrades. Don't get it sitting at a path lab and get sent to Brisbane 3 days later. It's got to be measured cool down, spun down. So if you've got a level of 5 micrograms per litre, it goes up 20% to 6 plus 2 to 8. It's actually a significant mast cell activation record. And with mastocytosis, you get these big welts, but you get post-inflammatory hyperpigmentation. And when we do biopsies, they show CD1 kit at a certain mutation, they're clustered and they're spindle-shaped. That's very different. This is a confusogram looking for all the different categorizations. You know, do they meet the criteria? And even if they don't meet even if they've got the criteria fulfilled, we have ICD-9, the International Classification of Disease, has classifications for this. Not a made-up condition if you've got ICD. Yeah. So you can actually make these classifications and diagnostic criteria, even if the NDS doesn't recognise them yet. Other mast cell activation diseases describe the condition, get a management plan. And even if you can't make the diagnosis yet, and you think it's going on, think about the differential diagnosis that I will go through and plan to manage them and plan to follow them up. Now, chronic spontaneous urticaria is a condition where mast cells are activated. So most of it is your patients. Anybody got chronic urticaria or had chronic urticaria? Yeah, a few. Yep. This condition, in 85% of the case, we're actually allergic to yourself. So the body sees yourself as danger and makes antibodies and the mast cells break open. And that's 85% is type 1A, which is autoallergic. Type 2B is actually where you make IgG antibodies against the IgE receptor, so you can be allergic to that. Most of it's thyroid peroxidase. There's IL-24, but there's over 200 self-antigens described. And that's the type 2. And I really don't need to, I've already done that. And diet. A lot of centres in Australia don't spend the time going through diet. The Royal Prince Alfred Hospital and Valencia Suit and Rob Lobley really led the charge with Anne Swain, a dietitian there, looking at diet. And the frustrating thing is with diet, there's a stack, and I think of a histamine bucket, but it's also a food chemical bucket. And also time of day. We're actually 60% more reactive at the end of the day than the start of the day. There's a diurnal cycle of clock genes that get involved with that. So Torsten Zubra in Berlin said that between 30 and 70% of patients with chronic spontaneous urticaria will have a layer of foods. But you need to go on a low chemical diet and to challenge that back in. And again, with going into diets, the big thing I'd stress is any elimination diet is an elimination and re-challenge diet. It is not elimination. The more poly practitioner that people are searching for because of FOMO, they'll get told to go on dairy, wheat, FODMAPs, low chemicals, and they end up getting into trouble and malnourished because the body says danger to the whole pile of them. If we've had a bad experience, our body learns to react. Lovely paper in Nature in 2nd of April this year where mice were fed grape Kool-Aid. They liked it, but until they got an injection that mimicked food poisoning. And their amygdala upregulated, and just the exposure to that would actually create the memory and release of neuropeptides of that experience. So people eat food they tolerate, should tolerate, they have the expectation, they've had a feeling of nausea just with eating, and they will get down to 1, 2, 3 feet. You've all seen these people. And yes, they're getting real symptoms because their brain expects it. And it's real. It's not in their head. It's in their head. But again, if you can get it, you can retrain it out. So you've got to tell the brain loudly, I'm safe. Don't let your autonomic nervous system take control because it does a shit job in MCAS. Get it to use your limbic system, use your powerful developed brain. So hypermobility, there was just a paper that came out recently saying, no, not associated with it. Yeah, it depends what papers you look at. And so when you look at, maybe a couple of million people, about almost 6 times greater risk. And there's a whole pile of genes that sort of may be associated with it as well. And we see mast cells and nerves amplify each other, as I've talked about, and small fibre neuropathy is common as well. Hyperalpha-tryptosemia is a condition that Jonathan Lyme described only several years ago. We're looking at 6.5 years ago as this condition, which up to 5% of the population they have. So we detect that when your baseline tryptase, we used to say more than 11.5, we're now seeing patients above 8. So if they have symptoms, we do that. What's important of it? Well, they're actually more likely to have idiopathic anaphylaxis. They're more likely to have worse systemic mastocytosis. The HBA is Hymenoptera venom allergy, so wasps and bee anaphylaxis. So it is important, and the proteases will actually cause blood vessels to leak and more likely to drop your blood pressure. This is just tryptase affecting some of the genes I was talking about, the protease genes, and causing more inflammation, which then can actually contribute to hypermobility. Interestingly, heparin, which is oozing out, can block type 1 and 3 collagen production. So you can be hypermobile with mast cell activation. And I've actually seen patients, like in a mould house, get out of the mould house, get well, get fit, foundations of health that I don't need to tell you about, and their hypermobility disappeared. They weren't naturally hypermobile. It was probably their mast cells, which also get stretched and get released, improving things. So testing for HAP, unfortunately, it's $169. Mucosal swab, usually about 8 weeks, and you need just to get registered in contact with gene by gene. But it's useful because if you've got that diagnosis of an extra copy of gene and you're going to hospital, they actually take you seriously. So, and then 50% chance one of your children is going to have it. And if they've got a raised tryptase, they'll actually, it'll be useful for them. So I've not had one single patient who's actually held back at the okay, it might be 270 Australian dollars. So MCAS, Mast Cell Activation Syndromes, basically differential diagnosis, different criteria. People are still arguing, kicking about, no, we're right with the definition, we're right with the definition. Multiple organ systems, essentially, we all can agree on. Definitely, we need to exclude other disease conditions, and again, all of them all agree on that. The 20% plus 2 is the Valent criteria, also called the Vienna criteria. Valent puts it into classifications for secondary and idiopathic MCAS and overlap, whereas the Weinstock talks about overlap with other syndromes. And Valent says, yep, do genetic testing. It is a waste of money and resources to do genetic testing at this stage. And I'll show you the data on that from a couple of major centres that have wasted lots of money. But you've got the capacity to do that. I tend to like the Weinstock approach. They've got a lovely review, which is somebody's put it on ResearchGate. So it is behind a paywall, but in ResearchGate it's not. As a downloadable practice. So basically all guidelines agree that MCAS involves recurrent symptoms affecting multiple organ systems. As I've said, tryptase is an issue, and many things like the leukotriene levels we don't measure in Australia. Heparin is the most useful marker, but heparin degrades in 5 minutes. So there's only one centre in Australia and Melbourne that will measure serum heparin, and it costs about $800. Because you've got to collect it hot, spin it down, and do that. So again, I'm not that fussed about it. Response to treatment is important. Symptoms are important. The Weinstock has a mast cell mediator score. And yeah, definitely look at primary, secondary, and idiopathic is a common framework. So the key differences, as I said, Valent has that level. And again, so Askia, our group in Australia, likes to have an elevated tryptase. And that's fine. We can get a baseline level and chase that. It doesn't hold me back on diagnosing the condition. And again, very similar overlaps as well. I didn't go through that. What I was talking about, what to think about, Harvard group and the Karolinska group, in fact, I'm actually doing work with both of them in microplastics at the moment. But this looked at a retrospective analysis of patients with MCAS sensitivity, more in females. Average tryptase was pretty high. They didn't find the c-KIT mutation in any of them, and HAT was diagnosed in 17%. So we've got patients coming with HAT with an MCAS diagnosis. Karolinska looked at 703 patients, and 31 patients were confirmed with idiopathic MCAS. HAT was detected in 3 patients out of 703. When this is a condition that's supposed to be 5% of the population, you would have expected at least 35 by chance. And their algorithm is, have they had an anaphylactic reaction, do all the baseline workups, look at IgE, look at HAT status, and then go do a $700 invasive bone marrow biopsy. For God's sake, do no harm. Whereas, let's go and have a look at the one that's in our silo that we know that's associated with mastocytosis. You might do a biopsy if you're having a rising tryptase, but I first go for a gene-by-gene analysis. But Gerard Molderings in Bonn has actually found the mutations that are associated with MCAS are very different to ones associated with mastocytosis. So again, being in their silo and just doing the ones associated with mastocytosis, don't get the answer. This is what I'm talking about, and again, you'll be posted out this reference and you can download it yourself from ResearchGate. Lots of organ systems, as you'd recognise in many of your patients, across, and it's not too hard to get all 2 organ systems involved. These are the markers, and we don't measure prostaglandin in Australia. Chromogranin A costs $60. It's falsely elevated if you're on PPIs. If you're on histamine, get off your vitamin C before you measure histamine. It could be elevated accidentally. But tryptase is an easy one to measure. Exclusions, look for endocrine disorders, diabetes. Hypothyroidism may make you sweaty and temperature intolerant. You may flush and go red with porphyria. Look for bowel disease of bloat and cramp and make you feel unwell. And in fact, with inflammatory bowel disease, you probably will get more mast cells there. In eosinophilic esophagitis, for example, an allergic condition, we'll see more mast cells in the eosinophil, in the esophagus, and those have been correlated with active disease. Carcinoid tumour can cause flushing as well. It can make people feel unwell and can cause respiratory symptoms. True food allergy can also cause this as well. The treatments, as a doctor, our role, we were taught to say, here's your diagnosis, here's your medicine. We've done that. As an allergist, part of my job is to do a bit of detective work and to get why. And I really must say my practice has changed with knowing an integrative doctor, Olivia Lester. She's in the States at the moment. Big fan. She's changed my framework of thinking, and I've got to acknowledge that. And I hope I'm a better doctor for it. Self-recommendation is no praise. But so look at the known triggers that we have that we breathe in, environmentally, dietary, H1s and H2s. We might go to leukotriene receptor antagonists. I rarely do those because about 5% will have mental changes. Treatment of POTS, which can be extra salts and compression garments and some medications. Flavonoids, but again, I'm cautious about too much long-term quercetin. Mast cell stabilizers like cromolyn or catolopin. And if people have hives that we can't find the cause of, we can get omalizumab, which is a top-of-line treatment. But treating the whole picture, thinking about the threats, that's what I do. I think about the medications, do that, which are Band-Aids. Nobody likes medications and being medication dependent. We haven't come out in a situation where we're medication deficient. So the air, the noise, what we eat, infection is a threat. Vaccines are a threat for some people. Foreign materials, so implants, we see implant illness, injury. That can be surgery injury or it can be physical injury. 75% of ME/CFS is post-viral. 100% of long COVID is post-viral or post-vaccine, which has been published as well. That's not controversial, but it's just not in the guidelines yet, the World Health Organization guidelines. talking about post-acute syndrome of COVID, PASC. Everybody still calls it long COVID, but in their definitions they don't mention that it's associated with post-viral, which it is. So chemical radiation and microbiome are our threats. And now our well-being, foundations of health, is good sleep, good movement, good nutrition, our purpose, our sense of being, and our belonging to our tribes. Without any of those, we're actually sitting on a stool with one leg. This is the five-legged stool, very stable. And it's hard to get well if you haven't got that right. We're sleeping 1 hour less than we did a century ago. Maybe technology, maybe too much bad reality TV. I was in a lovely hotel in Germany, and they actually had on the wall, if you don't have enough time in your life, turn your TV off. Now, this is a paper I actually wrote to one of my good mates, Jonathan Bernstein, was the editor of that. But Jackie in practice last year said that, this is, we get the diagnosis, but this is an allergy journal, my journal, and it says these conditions are a bit too emotionally taxing for the clinicians, and they're often occasionally accompanied by vague diagnostic courses, and they impair quality of life. But they actually say, here's some depression and anxiety checklists in their paper. Tick them off on that and send them off to a psychologist because they're a bit too heavy on us. So, but Helen Davis, if you're going to read one paper on long COVID, this is a paper. She said 4 in 5 patients with POTS received a psychiatric or psychological diagnosis before their POTS diagnosis, with only 37% continue to have it once they've received their POTS diagnosis. Now, you can get anxious and depression because of loss of function, loss of your tribe. So that's not necessarily due to the illness. And we overestimate mental health disorders. But I think also we underestimate as clinicians the ability of our brain to heal and take control. One of the mantras I now use, which I can see bring joy to my patients' faces, if we can get into it, we can get out of it. If we can get into it, we've just got to find the right path. And there's many paths as well. Recommend the 10-minute talk test. I'm not going to spend much time, but you can actually, rather than costing several hundred, well, next to $1,000 to get a tilt table done, this has been validated and you can actually do that. You can also use it to test any interventions. Some people talk a rise of 25 of heart rate with lying to standing, and they don't have to stand the whole 10 minutes. If people are tapping out at 3 minutes, get them to step away. But you can, if you're doing treatments, see if it actually works. Now, in ME/CFS, we've actually found and reported on mast cells being being present in the peripheral blood. You don't see this in healthy controls, but we see this in ME/CFS, and there is overlap between ME/CFS and long COVID, and also Mast Cell Activation Syndromes will actually have some similar features as well. And the more severe it is, we seem to have that. But we also see these mast cell precursors in patients with mastocytosis. And again, that was 8 years ago or something. 8 years ago we published that. So that's the MCAS overview, and I'll say thank you. And then I'm going to do a dive into microplastics that Reine. Yeah, there's hand that maybe the end of it, because this will do your head in. So microplastics, I'm actually have the opportunity to talk on this topic at IACI, which is the biggest world stage for allergy. So I've got 2 symposia at that meeting, which is it's an honour and privilege. So you've all heard of them. Are they involved in allergy and phthalates as well? So our world is more and more polluted. Thank you, ChatGPT, for that image, but it'll make you feel sick. In microplastics, a bit of terminology. There's bigger plastics, mesoplastics, microplastics are down to a micron, and nanoplastics. And people have been looking at microplastics. The biggest story probably is in nanos. So we're talking about when you're at 10 micrometers, you probably pass through alveoli. At 1, you're going to start going through gap junctions in the gut. And These are the levels. 200 to 40 is the shards that we're finding in the brain. Well, actually, I'm not finding it, but Matthew Campen in Albuquerque has published on that in Nature in February. You've probably heard of that paper. So where our microplastics are increasing, but they're increasing exponentially. We're just going up and up. Where do we get them from? Over a third are synthetic clothing. As we wash them, they leach out. Our tyres are almost 30%. City dust from breakdown of plastics, plastic bags, plastic bottles, PVC flooring and tubes, 24%. Road markings, 7% of our microplastics in the environment are from the road. Marine coatings to stop things growing on boats, 3%. Personal care products, only 2%. But still, we can make changes there. So it gets airborne, it'll be in the mountains, it's water, vegetables, and we're actually seeing them in the smallest fish first. So our really good foods, our high oily sardines and herrings, have got more microplastics than the bigger fish at this stage. And we're even bigger fish ourselves, but we're getting it everywhere. Carpenter and Smith first observed microplastics in the Sargasso Sea over 50 years ago. But 21 years ago, the British scientist Richard Thompson coined the term microplastics. Bit of terminology, the plastosphere, the ecosystems of microplastics, including bacteria and fungi that colonise the plastic debris in an aquatic environment. It's not sterile, but microplastics can absorb heavy metals and persistent organic pollutants, and even bacteria. Now, additives in the microplastics we have include phthalates, amines, pigments, acetates, leads, and even fecal material. I've actually had some microplastics. So anybody who's wearing recycled plastic clothing, yeah, good luck. But I actually was doing an experiment. Had some. I found out I'd left some after speaking to Matthew Campen. I actually had left some plastic bottles in the back of my car. I had a case of them in the back of my car for 2 years, and they'd gone all cloudy and the plasticity was lost. So I actually microheated them, stuck them under UV light, and then ground them up and dehydrated them. They smelt of shit. And this is the plastic drinking bottles. Anyway, where are they in the human body? Everywhere we look. And this is actually the work by Matthew that got published in Nature this year. That you've probably it was in the news for about 8 months before it made press. But they looked in patients who died in 2016 and 2024 in liver, brain, and kidneys, and high volume areas. And one of the types of most microplastics, largely polyethylene. But there's a range of them. So just looking at gametes, so sperm's a great place. Of course, we've had a 40% reduction in sperm in the last, 50% in the last 40 years. It's a great place to start because it's where life starts as well. I will talk about oocytes shortly as well, but they damage the blood-testis barrier. They create oxidative stress. There's germ cell death, apoptosis, disordered motility, genetic mutations, low sperm count, and infertility. And recent biopsies data suggests, here we go, about 100% of testes biopsied. Doesn't sound like fun. We've got some sperm samples, up to 50% of sperm samples are finding microplastics present. Oocytes, we know that microplastics are associated with decreased maturation, decreased rates of fertility, and apoptosis, cell death of oocytes. Microplastics have been found in maternal blood. Levels have been associated with miscarriage and premature delivery. In the fetus, it's been found in the placenta, the amniotic fluid, and their feces. Their first poop already contains microplastics. 38% of blood samples in last year, so breast milk samples, were associated with microplastics, and it's associated with changes in the microbiome, and associated with epithelial integrity issues. The really funky thing is if you actually replace the gut microbiome, the effect on epithelial integrity can be changed. We have changed to plastic bottles and we heat them in the microwave and they come out of tins that are lined with plastics. And there's up to 16 million microplastics per litre of heated formula. And up to 4.5 million, it's estimated kids probably get up to 4.5 million pieces of microplastics per day. Now, I said the big story is microplastics. People have been talking, 2019 we're talking microplastics. We might have 50,000 units per year consumed. But in heated food that's been stored in plastic, we're getting up to 2 billion nanoplastics per cubic centimetre, actually, microwave per 3 minutes. Up to 30 million microplastics per annum, and the levels vary indoors and outdoors depending. If you're like here, it'll be similar to what's outdoors. Very low. But if you've got plastic everywhere, you've got vinyl flooring, it's going to degrade and you're going to breathe in more. Our drinking water, again, early data back in 18, talking about 240,000 per litre in mainly nanoplastics. So we're looking at microplastics in 93, we're looking at nanoplastics, 240,000 per litre. If you boil water, you reduce microplastics by about 90%. I was thinking, oh great, you're going to turn them into microplastics or let them go into the air. But no, they actually go into the calcium that's present in the water. So if you've got more calcium in the water, great, and then you filter it, you can filter it out. So boil, filter, double. Just saying double route, we get hit. It's actually in high amounts of sea salt, funny enough. Honey and sugar has microplastics. It's in the seafood, it's in our drinks, and it's in our air. This paper was late last year. They actually had different tea bags, the nylon ones, the polypropylene on the cellulose ones. They isolated and looked for microplastics and put them in different enteric cell lines. And they found that there were billions per cup of tea heated at 95 degrees. So as Reine has here, as loose leaf tea, if you're doing a coffee, again, press is the best to go. And these are entering the DNA at this level. I'm talking about 1 microgram in the intraepithelial gaps. At nanos, they're going into the DNA, and they show this in this paper. So this relates to Matthew's work. What they got was brain tissue from people who died, and they used perfluoric acid to degrade the brain. And out of the average human brain, they found that 0.5% of the brain weight was microplastics. In 2016, half a teaspoon. If you had dementia, it was, 2024, it was 1 teaspoon. If you had dementia, it was up to 10 times that volume. And so we have a doubling in an 8-year period, which is scary. The average age of death was 54 in Albuquerque. They are young, and they had it validated. Now, so that trajectory is looking good. But you saw that trajectory that I showed of the microplastics accumulating in the environment. That ain't linear. I asked Matthew to, if you could actually crunch the data. We're recording this, but this isn't going. This is to registered only, isn't it, rather than the whole world? Yeah, good, okay. We can cut this, but it probably is good. But this is looking at a doubling every 8 years. But when I asked Matthew, and again, hasn't published this, I said, can you look at the younger quartile to see the rate per population? He said, it's not linear. It's X. It's logarithmic. So, but the FDA has assured us that in July 2024 that current scientific evidence does not demonstrate that levels of microplastics or nanoplastics detected in human foods pose a risk to human health. So that's great. Thank you. Thank you. And what's better, they've actually been kneecapped and haven't got any funding now with the new government. So the ostrich, the willful blindness is just going. So with microplastic and allergy, when we've got allergic conditions, we've got more surface area to capture that, and we've got damaged epithelium, which is going to enter. And we're actually looking, again, with Harvard and Karolinska, NIH has said they're not taking grants in. We've actually had our grant up for review, been announced that they're actually going to review it, which is lovely. So we're maybe Robert F. Kennedy might have some vision in this area. So we're looking at real-world samples of patients at EOE and looking at their genomics, proteomics, metabolomics, and microbiome. But we're also getting explants from these growing up from culture and putting with exposure. And using some of our tools, we can actually look at gene pathways and work out what they do. But our innate, sort of primitive ways of looking at microplastics will cause a range of inflammatory pathways. And what drives allergic responses? I'm not going to bore you with this. I'm going to bore my colleagues in Europe. But if we click the animation there, again, I'll let you do the tech. This is actually talking about apoptosis. Now, you've heard of apoptosis? This is how cells die normally. I had a graphic animated create this for me. Actually, another illustration. So when cells die, they actually start to detach from each other when they're dying naturally, apoptosis. So they withdraw nice and pleasantly and quietly from the social situation, and the cells reattach, and everything's hunky-dory. Yeah, so when a cell's dying from apoptosis, the nucleus, from non-programmed cell death, which is a cell injury, it actually releases neurometers. This seems like a ton, playing with steps. So there's a range of mediator releases, and there's something called high molecular group OX1, which excites dendritic cells to mature. They'll excite T cells. They'll tell antigen, look out for whatever's about, because this is probably what's causing what's going on, which can promote allergic responses. And it's very important in transferring from a dendritic cell to a T cell information about what's present. Innate cell death just here. So a little macrophage coming up to a bit of microplastic going on there. It tries to kill it, but it can't. It releases a whole pile of chemicals, which then are associated with different forms of cell death, which is necroptosis, pyroptosis, and ferroptosis. So range of inflammation and phthalates, a range of chemicals to make things nice and soft and flexy. And we can inhale them, we can breathe them in, we can wear them as well. And they're known to interfere with hormone signaling and to affect estrogen hormone pathways. It does push things down towards a Th2 response, a T2 allergic response. They're associated with endocrine disorders as asthma, metabolic syndrome. I've actually taken ADHD out of this because I'm doing it for an allergic population. And the vulnerable are the young. They're the pregnant. They're the women and children. The people eating junk food with plastics and processed foods, people who can't afford fresh food. So they're getting injured. And it's up to 10 to 15% of microplastic mass can be associated with additives. That varies from region. They get leached into the soil and they bioaccumulate into animals and also into us. They'll create airway inflammation. Allergic sensitization seems to be associated with that. So they seem to, like pollution, they can amplify allergic responses and make us develop allergies to things that we normally wouldn't. They can disrupt our barrier and then it can enter by abnormal ways for us to become sensitized to. We know there's immune effects in allergic rhinitis, as I just showed you a picture, that we've got a greater way of trapping and capturing them, and the epithelium is already damaged. There's been epidemiological evidence with children with PVC flooring in their house have double the risk of allergic rhinitis, and data from the National Survey in America correlates urinary phthalates and allergic rhinitis symptoms, especially in children. So experimentally, it increases sensitization to airborne allergens in mice. and nasal epithelium exposed to phthalate show more markers, as I've mentioned. So we can get skewing to allergic responses, we can get permeability, both of the airways and also the gut. We may get microbiome, or we definitely do get microbiome alteration, and we have an adjunct effect. So if you've got an allergen there, and also pollutants, you'll be more likely to develop allergy without these irritants there.
Okay, 5 minutes.
5 minutes done. So reducing exposure, lifestyle, again, you can see it here. So get rid of the synthetics, use glass, use a microfiber filter if you've got one, HEPA filter, avoid glitter, don't bedazzle yourself, filter your drinking water, don't drink plastic bottled water, avoid Glad wrap, choose fresh or frozen over canned. Many cans are lined with plastic resin. Limit your salt, honey and seafood from polluted areas. Personal care and hygiene, avoid your plastic microbeads. They've been banned in Europe. Use bar soaps or shampoo bars, or actually recycle your plastic. If you've got plastic bottles, recycle your liquids. You don't have to do those. And use natural products for health hygiene purposes. Avoid single-use plastics. Don't microwave the plastics. It's an amplifier. Support policy in reducing plastic bans, dispose of plastic waste, and educate others. Really cool thing is there are fungi and bacteria that eat plastic and destroy it. Reine said, talk about your skin stuff. I've got a skin product range that I don't, and again, we can cut this out to not be advertised because I don't want to advertise, but it's nice stuff. I'm proud of it actually, and we're winning awards. About 15 years ago, I was looking at trying to get eczema better, and I was using some seaweed products. And when I did that, I got a combination of seaweeds, which were called marinoplex and registered as marinoplex, which are antioxidant, anti-inflammatory, anti-collagenase. They block elastin breakdown. They stop sugar sticking there. They're antimicrobial. They block tyrosine kinase. They increase stem cells. They increase autophagy. They reduce. They get rid of senescent cells. It's magic what they do, and it's developed in nature over hundreds of millions of years. So we whip most of the known mechanisms. This is actually talking about collagenase, elastase, tyrosine kinase, and glycolase inhibition. And we're actually having a look at, originally, at hyperpigmentation and reducing hyperpigmentation. And we did cut down hyperpigmentation in the patients by about 40-50%. The spots reduced. But what actually surprised us was the reduction in wrinkles. So hence we developed that. And this is somebody who we used the products for 4.5 months, and you can see the change in that period over a 4.5 month period. We've had it tested both in Italy and US as well as Australia to look at the antioxidant capacities and the mechanism of action, and we've found where it works largely at superoxide, but also at blocking some oxidative stress radicals. We found an increase in an anti-aging protein called SIRT1, which is a master protein of lifespan, so that's gone up. And it's at a level that we want biologically. We don't want something to do a 500% increase in SIRT1, which may cause your cells to go crazy and proliferate excessively. That was September 2015. This year we've got about we got the best. We were able to put into liposomes, and we're in USA Today and LA Times. We got best serum of 113 tested, and we also got best anti-aging product. And I was just telling Reine that we've just been picked up by QVC for Q4 in America. So with that, when we're doing trials, we're actually noticing, including myself, I've been using this stuff for about 2009 since we started to play around with it, but I was noticing what I was putting in, my hair wasn't going grey, which was lovely. So being myself, I actually treated one side and left the other for 8 months. And you can see the difference at the hairdressers. And being myself, I actually looked at I found 1,200 genes changed in the stem cell bulge, which is where melanin and also hair follicular growth come from. And so we measured that. And again, I'm getting my prototypes out from the States this year. We're manufacturing in the States. I saw the slides from the States and US. The medical board says, don't tell your patients about this, because they might feel forced to purchase things from you. I'm just mentioning because Reine, we've had a chat to Reine in the last 4 or 5 months and said, we'll be able to get you some stuff down here, and she can sell stuff. So that is that. So thank you very much.
Come on in. So it's been 6 months since we've opened our wellness rooms, and I want to come and show you what the features are. So first of all, we have the blue light blockers. So there's 3 different switches: full spectrum, partial blue lock, and full blue lock. And that's to help reset circadian rhythm and to assure deep sleep. We've used all non-toxic paint. So when you're closed in your room, you're not inhaling VOCs, which are incredible endocrine disruptors. We've used all natural fibres in the room as well. You've got little blue light blockers here. So you can go to sleep and read your book. Sleep deeply. We've done no wiring in behind the head, so there's no dirty electricity while you're sleeping. We encourage you to charge your phones away from your head, and we're a Wi-Fi free zone after 10 o'clock. So again, ensuring deep sleep. The other feature that I really love, apart from how beautiful it all is we put filtered water on. So all the water that's coming through that you're bathing in is filtered. And we put immersion tubs in 4 of the room. And these tubs are for us to have therapeutic soaks. So we can use herbs at therapeutic dose and soak deeply in the beautiful filtered water with our herbs. Yes, we've got all the Mukti products, no chemical, very beautiful bath salts. So for those that needed to stay a little bit longer, we have put kitchenettes in the room. And with these ones, we've stocked them with all non-toxic kitchenware. One of the other features I want to mention is our air quality. A lot of people are trying to escape mold. And so we're filtering the air, and by keeping the room at a certain temperature, we're preventing moisture from developing. The room have access to our beautiful garden. The collaborative healthcare support is really what initiated this model. We have some of Australia's most amazing integrative doctors, naturopaths, psychologists, all working on that body, mind and spirit level, which we know complex chronic health affects all bodies. It's not just biochemical, it's biophysics as well as biochemistry. It's emotional, it's spiritual, it's psychological, and it's physiological as well. And by bringing those bodies together, those bodies of knowledge, in the name of a patient-centered model, this is where we really make a difference. But this is the space for people to come and really integrate those awakenings